So as I was taught the liver transplant patient arriving in your hospital, and I've deliberately chosen that patient irritatingly arriving on Friday for good reason, and some of the do's and don'ts. The first thing is this is not uncommon. If you think there's 766 transplants in England and 65 in that other country called Scotland each year, that means that every year those patients, if you assume that there's a sort of 95% survival, those patients are coming from all over the country, then going back, and at some point may well end up in your hospital. The important thing is that the management of these patients is not difficult, and it's blessed by the fact that the differential diagnosis is really quite limited, and I'll come on to that. And don't be frightened by these patients. So the fact that they, let's say, come in on Monday with a myocardial infarct doesn't mean that the cardiologist should ignore them until the transplant centre has taken them on for what was actually a straightforward angiogram. One needs to get on and manage those patients, and particularly because these patients may well stay with you in the current era of difficulty transferring patients across. We're waiting for COVID screens, etc. That is not a reason to delay their care. So those patients may well end up staying with you far longer than they used to. The patients also should not be frightening to you as a doctor, but the patients can sometimes be frightening because they'll say, well, in my transplant centre, I got a CT scan in 22 seconds, and you've taken at least 24 hours to get a CT scan. And that is the truth. They are often quite wedded to the transplant centre, but again, don't be put off by that. Just assure them that you have been in contact, etc. And those are the recommendations that the transplant centre have asked you to do. So just to sort of put them back in their box a little bit. So these are the important facts, though, that you, the clinician, needs to know when this patient turns up to accident and emergency. And the first is, what day was their transplant? Because obviously if it was 10 years ago, they're going to have different disorders compared to, let's say, if it was 2 weeks ago. You need to know what their original disease was, and then you need to know what type of transplant it is. And the patient will often know this, and they'll use terminology that says, oh, I'm told I had a DBD or a DCD. So either a donor brain death or a donor cardiac death. And DCD is important because there's a warm ischemic time associated with that, and an increased incidence of ischemic biliary cholangiopathy, even if they're on a perfusion machine. So that's an important piece of information. You need to know if it was a whole or a split graft. If it was a split graft, they often get a segment 4 ischemia. They may have a bile leak from that cut surface, so they may have an abscess in that area. So knowing what sort of graft they have is important. Importantly, you need to know their CMV or herpes risk. So if the donor is CMV IgG positive, but the recipient is negative, so what we call D plus R minus, they are at risk of severe CMV disease, which may present earlier than the usual sort of 4 weeks that we sometimes see in the transplant patients. And likewise for herpes, we actually had a patient have severe herpes recently. Strangely enough, an intravenous drug user who was actually herpes IgG negative. He got an IgG positive donor and ended up with systemic herpes. You need to know what complications that patient had during their time of their transplant. So if they were discharged after 10 days, you're looking at one sort of patient. If they were discharged after 3 months, you're looking at a very different sort of patient. And things such as their rejection load is important to know. So if they had 2 or 3 episodes of rejection with methylpred twice and then ATG at some point, you're looking at a heavily immunosuppressed patient, and you need that information. So the complications, let's say abscess, etc., post-op, you need to know. And then obviously recent events which brought the patient back to their hospital. So you can now ring up the transplant centre. You're now armed with some pretty powerful questions to really put the transplant registrar back in his place when he starts to get a bit snotty with you. And this is the differential, you see. If you know this, then you can actually become a consultant transplant hepatologist. The surgical complications actually tend to occur quite quickly. So hepatic arterial thrombosis, that will result in the liver not doing very well. The ducts fall apart, they develop bilomas, and they will present with fever and very unusual looking imaging. And we'll talk about imaging as the investigations for these patients. Again, anastomotic strictures may present usually quite early. The important thing here is that ultrasounds are not always diagnostic. The bile ducts don't always dilate within the liver in the transplant patient. So requesting an ultrasound and expecting it to show dilated ducts in the patient who has actually got an anastomotic stricture may lead you down the wrong direction. Sepsis can occur early or late. I've just touched on the CMVs, for instance. They may be weird, there's no doubt about it. These patients are immunosuppressed, and you can grow literally a sort of garden sometimes in these patients. Fungi, viruses, mold we've had, which is fairly unusual. Rejection again can occur early or late. Typically will present with abnormal liver function tests in the transplant center. They may present to you in a different way. If they're presenting jaundice and itching and their ducts are normal, then that's on imaging, that's a real worry. You're thinking they've developed ductopenic rejection. And I put that, those patients need to be shipped over pretty quickly. Drug-related is probably the commonest reason these patients are coming to the hospital, and that's because they've come for a transplant clinic, their potassium has come back as 7, and they're asked to represent to their local hospital because they've taken the train or bus home, and they're hyperkalemic, and they may end up being admitted into hospital because of hyperkalemia and management of that. Tacrolimus can also cause problems, and these patients can become quite unusual, shall we say, with a press-type reaction with a tacrolimus. And then as gastroenterologists, you'll have seen mycophenolate affecting the gut quite commonly. The cancers, they can occur early or late. PTLD, actually, you sort of think should be late, but it doesn't. It can occur within 4 to 6 weeks in some patients, and particularly in the pediatric literature has been shown to occur early. The skin cancers usually are late, but they present differently as well. So a small lesion can be biopsied as identifying a squame, and then you actually find that there's metastatic disease in the lungs and in the bones. Obviously, the original disease can recur. Hep C used to histologically recur very early, within 8 weeks. That's all treated now, but autoimmune diseases can recur. And alcohol, I guess, potentially could occur any time, but hopefully we've screened that out. And then, of course, the non-transplant related presentations, the myocardial infarct in the diabetic, etc. And just because they, I'll repeat it again, just because they've had a transplant, the management of that myocardial infarct should not differ from any other normal patient. So for the registrar, house officer, SHO, whatever, clerking the patient, naturally one needs to take a history. Important, I've given you on slide 3 what the questions you need to ask the patient, but also ask about compliance and ask about new medication. So one not uncommon event is a course of antibiotics, usually erythromycin for a chest infection, and the impact erythromycin has on tacrolimus levels, and the patients come in with hyperkalemia and renal failure. Examination, investigation, I'm going to touch on investigations, and then the phone call to the transplant centre. Now, you can send your house officer to do that. If you're a gastroenterology registrar and you want a job at a transplant centre, don't do that, because the house officer will give us some information, and then he'll go back to you because we'll ask for more information, and you end up with this yo-yoing of conversations. So have someone who actually knows about the patient and is fully informed of the history and knows their blood results that are in front of them and a chest x-ray to make that phone call with the transplant centre. And then whilst decisions are being made, we need a contact number, and a mobile phone number is often not that useful, because if somebody leaves on Saturday morning having done a Friday night shift, and then hands over, then we'll be ringing them as they're tucked up in bed getting their recovery sleep. So a bleep that's actually answered is an important thing. Now the investigation is actually, I'm not trying to teach you to suck eggs, but actually there's some nuances to this. Send off the tacrolimus level at the same time as you're taking blood. Do a blood culture and MSU, and if you're going to look for CMV, don't send off antibodies. You need to send off a PCR, because antibodies will be a waste of time. A chest x-ray, if you're going to request an ultrasound, make sure it's a Doppler ultrasound looking for the arteries and veins. Now, we're talking about a patient who's turned up on Friday, and actually weekends, our experience is we can get a CT scan quicker than we can get an ultrasound, and it's because they're protocolized, and the ultrasound will need to be actually done by somebody who's experienced in Dopplering hilar vessels. So it may actually be more sensible to request a CT scan, and if you request a CT scan, you specifically want to ask for a triple phase CT, and you might as well include the chest as well. And the triple phase is because you're looking for the arterial phase to look at the artery, and then you're looking at the venous phase to look at the portal veins and the hepatic veins. So by specifying that, you will get the information that you need, because you need to know what is the state of the liver, has it got any lumps or bumps in it, and is it well perfused. Then the management of that patient who, let's say, has come in with fever on the Friday into the weekend, start some sensible antibiotics, and if they're sick, add an aminoglycoside. You want to cover gram-negatives, and then you'll need to know whether the patient has, for instance, CPO, a resistant Klebsiella, etc. So that's an important piece of information from the transplant centre. Give them some IV fluids. If they're jaundiced, they need to be shipped over unless their ducts are up. And if there's a mass lesion, they're heading towards a biopsy. So this is a good example of fever and a mass lesion. You can see the mass in the right lobe, and then there's a PET scan, which in some respects doesn't help you, it just shows there's something wrong. But the biopsy shows you there's PTLD in this patient who is on the ward currently and is having treatment. The Friday night specials are like this. So this is a patient who turned up in April, short of breath post-transplant with that chest x-ray. And you can just imagine in the binary era of COVID medicine in May, that the first diagnosis that people were thinking of was that this patient has got COVID. Now, interestingly, they had a CT scan and the radiologist felt that this was more consistent with an atypical pneumonia, I think because of the lack of the patchy change. But what's interesting was that the team very sensibly thought, well, we can't do much about COVID in terms of treatment, but we can cover CMV, and this patient ended up being intubated overnight from Friday into Saturday, and the team not only covered CMV, but they recognized that CMV is often associated with PCP, and whilst they're waiting for the beta-D-glucan, which goes up in PCP, they covered both over the weekend, made sure the right things were being treated. Yes, the white count will get a hit, but sure enough, the BDGs were sky high and PCP was cultured. And so by appropriate action from the local hospital, this patient survived what is clearly a very severe pneumonia. So what does the transplant centre need to do? Well, the transplant centre needs to help you manage that patient and not be condescending and say, oh, why haven't you got a CT and an MRI and an angiogram within sort of 6 hours, and recognise that those things are not always straightforward, and help guide that management, potentially accept the patient. And I think if you're struggling with the management of the patient, it is not an admission of failure. It's often because you recognise something's wrong. Things may be going in the wrong direction in terms of if the patient's improving. You're struggling to get the investigations, and you're doing all the right things as a caring clinician, but that you recognise that things need to be happening a bit quicker. Now, under those circumstances, it's amazing. A consultant-to-consultant phone call will often speed up that transfer. So don't be afraid to pull out that gun. My final slide is this one. So you can actually, we can get some answers hopefully in the emailed or messaged across. So this is a patient who's presented with jaundice and fever, again, into his local hospital. And my question then to the audience is, what do you want to know which will allow you to make a diagnosis and manage this patient appropriately? bearing in mind that as we head into COVID lockdown again into London, that transfer may not occur. Thanks very much.
Thank you very much, David. There's a couple of questions that, or comments. So the first comment was about whether an online referral system would be an easier way for non-urgent questions.
So that's a bit like the neuroinjury units often used, don't they? And for transfer to a neurosurgical unit. We don't have that facility at the Royal Free. Obviously, one needs that email system to be monitored the whole time, but you will often then, again, for that neuroinjury system, there's a box-ticking exercise that's required. So it's about having the right information and that being transmitted, and also the people who are receiving that information providing the right information back.
So yeah, it can work, but it needs. So the second question is, how common is anastomotic vascular thrombosis in post-transplant period, a month or so down the line? Should we start anticoagulation?
It's unusual. So we will often identify a patient as a high-risk vascular patient, and they will be either, if it's arterial, they'll be on aspirin. If it's venous, they'll be on full anticoagulation. So that's actually quite unusual. So usually the vascular thrombosis will occur early, but the advantage of that CT scan when they come in or a Doppler ultrasound, that'll give you the answer straight away. And you'll get that sort of geographical abnormality of the perfusion in the liver.
Most patients you discharge on aspirin normally.
Yes.
And I think maybe that's an answer for your question here.
So they want to know the CMV status. Well, the imaging I've shown is actually an MRCP. And CMV status won't normally...
You need DBD or DCD.
Correct. So the correct answer, the most important piece of information has actually come from the chair here. So I think that's cheating, actually. But he's absolutely right, because that's an ischemic cholangiopathy. And so knowing that piece of information, the patient actually presents with abnormal liver function. You'd think about cholangitis in that patient, wouldn't you? They've got a nasty hilar stricture. And whilst you're awaiting transfer, treat with antibiotics.
We have some more time for further questions. So
should we make any change in immunosuppression for septic transplant patients? A question we get asked the whole time. Tacrolimus, no. Mycophenolate, we probably will stop mycophenolate. Its impact on the the patient's immune status, I think, takes a while, but it's not uncommon that we'll stop mycophenolate in those patients. And then I think, do you like being informed straight away or only after we've done the CT, etc.? That's very nice. I think actually straight away. Clearly, if the patient's sick, they need appropriate management, but earlier always rather than later, because actually there may be some information that we can hand over straight away. But I have to say, I do quite like the Leeds neuro thing, and we will have to think about that.
I have a quick question. Do you want to know about every patient from your unit admitted to hospital for any minute reason, or it has to be kind of a clinical judgment that this patient has some simple problem, treat him like anyone else, and go home?
Difficult one. I think I'd rather know, actually. So the transplant coordinators will often take a call that a patient has been admitted into hospital, and there's no issues at all with that, and they're being managed entirely appropriately. It is impossible for the transplant units to have all these patients coming back to them. Absolutely, that's not the right way to manage them, and more they need to go back to their referring hospital and be looked after that. And it's a very much a hub and spoke shared care model, and it's all about communication, actually.
There's another question here. Would you manage biliary strictures differently in DCD and DBD?
The position of the strictures are usually different. So with the DBDs, it's usually an anastomotic stricture, and a DCD, it's unfortunately like that horrible hilar stricture, which responds not well to ERCP management. we will often try, but it's not a good outcome for these patients with complex hilar strictures, which then often progress as well over time. So with the enthusiasm for perfusing DCD donors, which is very much the rage at the moment with machine perfusion, the jury's a little bit out at the moment because it seems to remove the reperfusion hit that occurs when the surgeons open up the clamps. And when they weren't on machine perfusion, the patients would often become incredibly unstable and massive dose of inotropes. That's now gone, but what we're not removing is the biliary ischemia with machine perfusion. So we'll see, I think we'll be seeing more of it.
Thank you very much, David. Thank you.